I'm Sunil Badve. I'm a professor and vice chair of pathology at Emory University in Atlanta, USA. Uh, that's my official title. In addition, I'm a pathologist for the Eastern Cooperative Oncology Group and College of American Pathology Radiology Network. So ECOG acronym is a acronym. I'm also associate editor for JNCI, a deputy editor for NPJ breast cancer, amongst other things. Well, a lot of sand is shifting, and we don't know where we will be in a few years. But currently, we believe that breast cancer is at least of a few subtypes. And we kind of use the classification that was proposed by Chuck Peru's group in early 2000, which classifies as luminal cancers, basal cancers, and HER2 positive cancers. Obviously, with the passage of time, we have realized a few things. That this so-called intrinsic classification changes with the passage of time in any given patient. So a metastasis from a primary tumor, that is, say, luminal B type, could end up being basal-like on metastasis. So there is a degree of fluidity in terms of the intrinsic subtypes and the molecular characteristics of the tumor. And also, of course, are the advent or the big impact of the advent of antibody-drug conjugates. So we no longer treat patients based on their anatomic stage of disease, but we also treat them based on their biomarker status. And HER2 low, for example, has become a huge target for therapeutics. And many of these patients tend to be classically luminal positive tumors, that is, they are ER positive. Some of them are also what would have been called basal-like or triple negative. So the classification is kind of going to be fluid. In addition, within the basal category, we have lots of different subtypes. Some of them are BRCA mutated, some of them have homologous repair deficiency or HRD deficiency. Some of them express TOPO2 antigen and are susceptible to therapeutics such as sacituzumab govitecan or other types of anti-TOPO2 agents. So there is a lot of fluidity within this. And of course, we have androgen receptor expressed in in significant number of these cancers, and anti-androgenic therapies could have a role in therapies. So as the knowledge develops, as new agents become available for therapeutics, and as we better understand the mechanisms by which they act, what are the results or what are the mechanisms of resistance, we may need to classify breast cancer in a slightly different way, because that is what ultimately governs what and how the patient is being treated with. So the traditional biopsy consists of basically going through the skin into the tumor and taking a piece of the tumor. Now, this biopsy process is easy when you have superficial lesions, such as skin lesions, or even within the breast where access via needle is relatively easy, the complication rates are going to be low. But as we deal with metastatic tumors, which may affect lung, liver, brain, these kind of procedures are not quite possible. So the question then becomes is how do we identify what is the biology of these tumors in the metastatic setting? And one of the findings that was made a few years back now is that the tumor within the body disintegrates to some extent. Cells die because they're rapidly proliferating, and they release the DNA material, the genetic material within the blood. And we can use a blood-based assay for identifying the characteristics of the tumor. So this is a test that is not too dissimilar from your standard glucose test or chemistry test for your cholesterol or something like that. And this is now being used increasingly to identify the presence of the tumor and the characteristics of the tumor. And that is what circulating tumor DNA essentially stands for, that we are detecting the genetic code of the tumor by doing a simple blood test.